All right, welcome, Dr. Raphael. I'm so excited to have you on here, and I can't wait to talk about everything that we have planned to talk about. And let's start by, you want to talk about your background. I'm sure everybody listening already knows you, but just to
Yeah.
give us a little history.
Yeah. So people think I've been doing this forever. I really have not. I was practicing orthodontics as a specialist for 27 years before, should I say, the light dawned on me or the light bulb went
The
off
light
or
bulb went off.
something occurred to me. And it was actually from an article I read by Herman Ramirez, if your listeners know of him. He said in an article that soft tissue dysfunction is the etiology of malocclusion. The etiology,
Hmm.
THE. And everybody knows about thumb sucking and tongue thrusting and that kind of thing. And I had even in my orthodontic residency learned about soft tissue dysfunction and myofunctional therapy. But for the most part, it was something that I would pay attention to when I was having trouble with a case. And if I wasn't having trouble straightening the teeth, I didn't really think about soft tissue dysfunction.
Hmm.
And it didn't really occur to me either that the reason why orthodontists are using retainers forever is because of soft tissue dysfunction,
Hmm.
right? But and it took a while, maybe 6 months after reading that article, for it really to sink in. I just, I have a little bit of a thick head. Maybe I'm a little slow. I don't know. But it finally dawned on me that that is why teeth are crooked. And it's not just the tongue thrust itself or the aberrant swallowing, uh, you know, uh, uh, um, uh, postures and muscle function itself, but muscle function that goes awry early in life changes the way the face grows. And the way the face grows determines the size and shape of the jaws.
Hmm.
And the size and the shape of the jaws determines how much room there's going to be for the teeth. So if the teeth come in crooked, you know that the jaws didn't grow right
Hmm.
and that there was soft tissue dysfunction at the base of it.
Hmm.
It took a while to sink in, but once that concept sunk in, things were different. I could no longer ignore the soft tissue dysfunction as part of the etiology of malocclusion or in my treatment planning. I almost always have to take care of the behavioral part of the treatment because that's where the problem lies. You cannot just straighten teeth and expect them to stay forever because crooked teeth are, in fact, in balance with the rest of the body at the time that you start orthodontics.
Hmm.
And if you move the teeth, you're moving against the soft tissue function or dysfunction, against the balance of the body, which is really head to toe. We know this about fascia and posture and the way the head is stacked on the spine and the shoulders and all the way down, and how fascia that may be tight under the tongue, in the cranial sutures, in the neck, can pull on the body. It goes on and on and on.
Now, would you say
So,
that every
but that was
patient,
13 years ago.
yeah, would you say that every patient then that you see, you recommend myofunctional therapy for?
Yes.
So
Yeah.
it's funny, I feel, and I've said this before on another episode, but when I go to do a lunch and learn at an orthodontist office and they see the value in it, they want to start referring and they're like, just give me the quick and dirty. Who am I referring? What am I looking for? And I say, if somebody is in your chair, something went wrong. There is dysfunction present.
Right.
So, not that I'm trying to make you refer to me your entire practice, but they need to be working with a myofunctional therapist for retention, for stability of the results, for, better progression and all of that. So it's nice to hear that statement being, very supported.
Yeah. And I have to qualify and perhaps confess to you, because I know this is going out to the, myofunctional community at large, that the my first line of attack um, for myofunctional therapy
Mhm.
is with the trainer system,
Mhm.
because it is something that I can apply in my office. It's
Mhm.
something that I can administer to a patient without having to make an additional referral.
Right.
And that's a very important thing for dentists and orthodontists to understand, that there are ways that you can approach myofunctional training in an office without having to burden the patient. And I'm going to qualify that when I say that, to burden the patient with another referral, because until this becomes more of the, not the standard of care, but the cultural norm,
Mhm.
that myofunctional therapy must be done. And until we have enough qualified myofunctional therapists to handle all the kids with crooked teeth,
Because
we
there's so
need
many.
some kind, right, we need some kind of stopgap measure.
Mhm.
Now, that being said, I do have a myofunctional therapist here on campus. She has her own private practice,
Mhm.
and she helps me out with my trainer patients. The ones that are having a tough time, I'll get them over, and we coordinate our efforts with that.
Mhm.
And the ones that need remedial, and sometimes it's obvious early on, sometimes it's not obvious until we get to the tongue posture, tongue stretching exercises, and that kind of thing,
Mhm.
that I'll make the referral.
Right.
But by that time, the mothers have a much better sense of what I'm doing, what I'm thinking, what's wrong with the child, and the referrals go much, much easier.
I'm
I can
sure.
say to a mom, look, the goals of the trainer system are to establish nasal breathing, lip competence, tongue resting on the palate, proper swallow without having to use facial muscles.
Mhm.
Those are the four biggies. And I say, we've been using the trainer system to teach those four things, but your child's having trouble, with it. It's tough. Yeah, it's a tongue tie. It's a hyperactive mentalis. It's a uh, just a muscle tone problem,
Mhm.
breathing. There's so many things that fight against good muscle function, and some kids just need a specialist to work on it. And I say myofunctional therapy does exactly the same things that we do with the trainer system, um, but it's more highly individualized
Mhm.
for the patient.
Absolutely.
So, not to drive this home too far, but I tell them that it's like going to the gym. You
Yes.
you can go to the gym, and you've got that row of machines, and they start your upper body and they go to lower body. You can just run through the circuit,
Mhm.
and you'll get a pretty good workout. But if you're having trouble with the machines,
Mhm.
if it makes it hurt or it's hard to do and you need guidance, you can get a personal trainer,
Mhm.
right? Myofunctional therapists are the personal trainers of the dental world.
1,000%. And you totally nailed it with it being so individualized. I work with one of the local dentists, and we wanted to try out like a group program for those families that just really cannot afford the therapy. So we said, we'll try it. We'll see how it goes. And we're on, I think, the third session. And I had to talk to the parents. It's just everybody, who was tongue tied, who wasn't, who, had more dysfunction than others. It's so hard to get kids in the same room that can follow the same type of treatment plan. Everybody progresses so differently. So, we tried it. I was really hopeful that it would work. Maybe I was a little doubtful in the back of my head, but I tried to be positive. and it's not going to work out. So we're going to figure out a way to get them all the therapy they need, but it is so individualized, especially when you have all those other counterparts that you have to consider. And I know we're going to touch on, you were telling me how you did a talk for Talk Tools, and I love the title. I think it was Tongue and the Orthodontist, A Troubled Love Story, which is a fantastic title. But what I want to know too, because what I find is, even when orthodontists get on board with Myo, when I see the referrals come over, I mainly just see tongue thrust and low tongue rest posture and lip incompetence and mouth breathing and all the other things we know that kind of go along with tongue thrust aren't really noted. And I'm not saying maybe they're recognizing it and not putting it, but I feel like most orthodontists look at it as just the tongue thrust, just the swallow. We have to fix this swallow.
Right.
So if you want to elaborate on that as an orthodontist, how it's so much more than just this tongue thrust.
Yeah, so absolutely, because even though I had some training in myofunctional therapy back in the 80s, it still was, for me, when I was getting in trouble orthodontically, when I could obviously see the tongue fighting my work.
Mm-hmm.
And generally that happens at the end of treatment.
Mm-hmm.
So sometimes it was so obvious that I would send early on, and I would want the therapy done before I started the orthodontics so that I wouldn't be in such a battle. But for the most part, orthodontists can really, we can yank things around. We throw spurs and spikes and fences and all that kind of mechanical modality at the tongue, and we get away with it to a certain extent. But the ones that we don't, then we cry for help.
Mm-hmm.
But it's the wrong approach. It doesn't make sense any more than, say, you're trying to train your dog. You throw him in a cage and you go, yeah, now he's behaving. Well, yeah, but what happens when you let him out of the cage, right? The orthodoxies of orthodontics and the origin of malocclusion are also a problem, because as an orthodontist, I was told that there's the angle classification of both the teeth and the skeleton, and that the particular characteristics of a patient are the characteristics that that patient was destined for based on inheritance, and yes, maybe some environmental factors, but they see all those malocclusions, we are taught to see all those malocclusions as independent problems.
Mm-hmm.
Right? A class 3 is not like a class 2, is not like a class 1 crowded. They're different diseases.
Mm-hmm.
And yet, there's evidence within our own literature that the etiology of these problems is all the same. And I don't know if you've ever heard of the Harvard monkey experiments. Have you ever heard of this?
Oh, yeah.
Right?
Yeah.
Yeah. So you take 15 monkeys, you plug up their noses, and they can't breathe through the nose. They got to find another way to survive. 14 of them figure out how to do it. One dies. 14 figure out how to do it. And they all turn out with different malocclusions. Well, what does that tell you about malocclusions? Is that they're sort of serendipitous results of the soft tissue dysfunctions that that animal picked up in order to survive. And we see all kinds of patterns of soft tissue dysfunction, and they can have to do with breathing, and very often do. Mm-hmm. I think most malocclusions are the result of compensations that we adopt very early on from things like nasal obstruction and congestion and swollen tonsils and adenoids and airborne irritants and all allergies and all that kind of stuff. Also tongue ties, of course, become a very common way of hampering the movement of the muscles. But orthodontists just don't see that as the etiology of malocclusion. They can't quite wrap their heads around it because we are so indoctrinated in the angle classification. You know, the angle classification, which is useful, by the way, it does describe what has happened to the teeth. So it's a phenotype. But we use it as a diagnosis, and it's not a diagnosis. It does not tell you anything about the origins of the disease. So today's orthodontists have to take a step backwards and see things in a different way. But once you start understanding that all malocclusions can stem from soft tissue dysfunction, then they're going to start seeing the etiology at the beginning of the treatment. They're going to make it a part of their assessment and diagnosis and treatment planning.
Absolutely. Were you able, I know you were looking for slides before. Did you have it pulled up that you wanted to share?
Um, I think so. I have a couple, but tell me a little, ask me some more questions because
Yeah, absolutely. I would love to. So let's talk about tongue tie now that we kind of left off with that
sure.
and the impact that that can have on your treatment.
Mm-hmm. So, how well would you walk if you were born with your ankles tied together?
Not very well.
And how well would you walk if you waited until Brace's age, say, to have them detached from each other?
Not very well.
No. You'd be standing up for the first time or walking, you're not hopping anymore. It's just, what a mess it would be. So, when we see tongue ties that have not been attended to early on, and we now are, we now own a laser, and we want to get an ROI on the laser, and we see every tongue tie as a candidate.
Mm-hmm.
We release the tongue, and what happens? Nothing good. Not just by releasing it. Why? Because you've got to teach the tongue what to do. And you better do it beforehand, because when the surgery is done, no matter what you use, laser, scissors, or scalpel, or sutures, or no sutures, it hurts.
Mm-hmm.
And what kid wants to sit there and stretch the wound, right? Unless you really are motivated and taught and educated, and you know what the exercises are.
Exactly.
So this is my point on tongue tie. I do not rush to get them resolved.
Mm-hmm.
Now, I want the opinion of a myofunctional therapist to tell me what are the limitations of the tongue.
Mm-hmm.
And there may not be. You can see a tongue tie and a kid's getting his tongue up on the roof of the mouth. Sometimes the worse the tongue tie, the more the dorsum of the tongue is actually getting up and helping the palate. And it's a clever animal, the tongue. I really do. I think that it's got a mind of its own. It's sort of like, how we say we have a microbiome, and there's like a population, another being within it. I think the tongue is also another being. You can't talk to the tongue and tell it what to do. You tell it to go to the right, it goes to the left. You tell it to go up, it goes down. You tell it to stay out of the way of the dentistry you're doing, and it goes right forward. This is what I mean by the troubled love story thing. It's interesting trying to make friends.
Yeah.
Right, with a tongue. But yes, there should be a good assessment of the tongue,
Mm-hmm.
and not only just at the beginning, but as exercises are going on, how well is the child able to cope with the exercises? These are all exercises the child's going to need if and when you're going to do the release anyway.
Hmm.
I also like to see how much of the fascial restriction is under the tongue and down the neck and, to the shoulder girdle, if not to the sternum and the toes. That you want to make sure that the freedom is not just the tip of the iceberg.
Absolutely. And
And,
sometimes, we can't even really tell how much dysfunction there really is until we start working with the patient. Um,
right.
so it's very rare that I suggest it right off the bat. We want to work a little bit together first. Like you said, we have to, regardless if you're going to have it done or not. So let us really get to, make friends with this tongue and figure out if it is a love or hate relationship.
Right. Exactly right. And I think we'll be a little more successful because it's just such a disappointment when you send somebody for, say, a release and they come back and 3 weeks later it's a thick band of of tissue, and you don't want to say the words, I think we're going to have to do this again.
Right.
It's big disappointment. It's not easy to say. The parents are upset, the kids are upset, the performing doctor is upset.
Mhm.
We've got to really make sure that we're doing this right. That being said, if you can't get your tongue up to the roof of your mouth, you're not going to be able to support the orthodontic work that has been done. If
Mhm.
it's if it's palatal expansion, whether it's rapid or biomimetic, do it slow with growth. If you just align the teeth and the tongue is not there to coordinate its efforts, with the rest of the body, it's just, you know, then it's not going to hold.
Now, what kind of appliances? I know you use the Myobrace,
Right.
but what other appliances do you use?
So this may be a good slide to show.
Okay.
Let me find it because I have a way of thinking about this that that I think is helpful. Um, so I'll just share my screen here. You'll have to give me permission to do that.
Oh, let's see.
It's on the
Okay,
okay.
there you go.
Um, this mirrors my way of thinking about things, in that I believe that we need to address three major domains in